Good afternoon. I think we'd like to get started just because we want to stay on time and want to respect everybody's time and what activities you have. And thank you for coming in after lunch on a beautiful Friday afternoon for our talk. Our talk this afternoon, this is session 325, Blood Dyscrasias for Primary Care Providers. And as expected, we have people on either ends of the room because of the situation with the screens. So feel free to kind of stay out there where you can see. I have a couple things to remind everybody again. Just be sure that your electronic devices are turned to silent mode for the presentation. I want to remind everybody again that Posters on the Move is open from 7 a.m. to 7 p.m. tonight, but today is the final day. So if you haven't had a chance to go look at the posters, please run by and go see those. Tomorrow morning is the business meeting for NAPNAP, and it's from 8 to 9:05, and tickets are required. So be sure you have a ticket to attend the business meeting in the morning. And don't forget that on Saturday at 6:30 a.m. for those early risers, please come to our Zumba class. You don't have to be an expert Zumba person. Just be willing to move a little bit and get some exercise, and all that money goes for the foundation, which of course is for benefits you. It benefits our scholarships for students and research for our NAPNAP members. You can sign up at the registration desk anytime to go to the Zumba. That's all it's required. And now it gives me great pleasure to introduce Teria Giannetti. She is the chief nurse practitioner at Children's Hospital and the nurse practitioner in the hematology clinic and for hematology services. Teria has been involved in primary and specialty advanced practice care for over 36 years. She's also an associate professor at California State University, Fresno in the Department of Nursing and the graduate programs coordinator there. Her Bachelor of Science in Nursing is from Cal State University, Sacramento. Her Master of Science in Nursing and Primary Care Pediatrics is from Cal State University, Fresno, and her DNP is for Brandman University. She has served as the NAPNAP National Program Chair for 5 years and is an immediate past president for a local NAPNAP chapter. She also currently serves on the NAPNAP Foundation board. Her most recent publications include she's been a chapter writer for the textbook Pediatric Acute Care, A Guide for Interprofessional Practice. And she did Chapter 8, Patient and Family-Centered Care, which was published in 2011. And she's done review texts for the Acute Care PMP certification book, as well as articles for the Journal of Pediatric Healthcare and the popular magazine Ready, Set, Grow, which is written by pediatric nurse practitioners and distributed to over 1 million families. Thank you so much for presenting, and she's going to be talking today on blood dyscrasias. Join me in welcoming Dr. Giannetti.
It's always kind of funny to listen to yourself, and if you were at the sleep talk, this is your downtime. I recognize that. I appreciate that. So, just kick back and relax. But I hope I can provide you with a little bit of an inspiration to look at some of these blood dyscrasias, these blood diagnoses that we see that are very, very common, and that, yes, they may be diagnosed in a hematology center, but then they all go back to primary care. So I want you to be comfortable taking care of primary care children. Again, I have no financial disclosures that I need to present to you, and there's a laundry list of objectives. Again, my hat between being clinical and being academic, we write lots of these things, so read them at your leisure. I want to get right into it, and I really wish that children would come with their little owner's manual. It's estimated now that you're going to spend about $250,000 in a medium income family to raise a child to 18 years. So you would not invest $250,000 without having some sort of background and interest and knowing about what they're going to do. And yet, we've got a relatively indiscriminate activity, and you can be a parent. So if we had that opportunity, it would really make a big difference in what we know. With newborn screening in every state in the United States and its territories, we do have a lot more opportunity to have knowledge about what some of the hematological conditions are as soon as that child is born. So that has been a big step forward in trying to identify these families, get them to the resources that they need very, very early. I'm going to go through this whole laundry list. I'm going to talk kind of fast. You do have access to the slides. And again, what I hope to do is to give you some of the pearls and some of the tips about how as primary care, when your families come in and have these concerns or these questions, that you'll be able to reassure them, feel comfortable with your knowledge base, and maybe even have access to some specialists that you can get special questions if you need to. So I'm going to start with thrombophilia because this seems to be one of the biggest ones that we are getting these sort of off-the-cuff referrals where the parents are being referred in from primary care to our hematology specialty service because the family has a history of thrombophilia. Somebody had a stroke and they're starting to do the workup and they were told that this is hereditary, that this is genetic. And so now the family wants the children to be tested. And again, thrombophilia is not a disease, but it is an increased susceptibility, usually based on genetic factors, but also on environmental factors that put you at risk for having a blood clot. So why are we seeing some in kids now? Well, number one, the biggest one is the use of central lines, because once you put that in there, basically you've created an inflammatory process inside that vessel that then is going to create all of that opportunity for those cells to coalesce and to create a clot. So the use of those lines has really increased the number of clots we see in kids, and then we work up some of those kids, and I've got a list for you of when we work it up and when we don't, to be able to figure out, was this just the line that created this inflammatory response and therefore created a situation that put that child at risk, or was that just the tickler that, yes, with the inflammatory response, but they have the genetic or inheritable characteristics that put them even at greater risk? The other thing that we have is that if you do have 2 or more of the thrombophilia markers, those children are at really increased risk. And we don't test everybody, again, with our owner's manual, with our newborn screening, to see if we're carrying those markers. So we need to be cognizant that there are familial changes, but many people will have those markers and never be in a situation that they would be able to play out into any sort of clotting activity. Again, we do have a lot of things that are going on. We do a lot more invasive procedures. We have a lot better imaging. We have a lot better interpretation of our imaging, even with telemedicine, where we will send it off to another radiology center or another person who will be able to really understand what they're seeing. So we may be seeing things that are much smaller and may have been self-limiting, but because we've got the good resource, we'll be able to see them and therefore make a diagnosis and begin to start all the workup. We also have a society that is pro-thrombotic, which means that we have an increased sedentary society. We have a society of our young children that are overweight, and obesity is a huge marker for thrombotic events. We have young people that are getting away from smoking, but again, smoking is still a really increased problem that we see and is one of the risk factors for developing clots. Okay, who do I point this? Oh, there it went. No. There we go. Okay, I point it back there, I guess. So when do you test? And this is, again, one of those things that's kind of controversial, because if you ask a dozen hematologists, you'll get a dozen different answers. That's kind of the nature of the world. But the important thing is that without a strong family history, there is no recommendation really to do testing. So you're not going to want to just get that owner's manual, get that laundry list of things, at least not right now, because we don't have good mechanisms to be able to see, okay, yes, you might have one of those markers, but who knows if it's ever going to play out. So again, without strong family history, to even test children is very, very controversial. And at my particular center, we try to discourage that completely. If they've got a strong family history, and I think it's in one of the next few slides, then we will try to maybe encourage some parent testing, partner them up with some of the adult hematologists, but try to avoid testing the children. This is the laundry list of the tests that we do look for, and if you have these particular changes, then those are going to be the markers that we're going to put you at risk for developing a clot. And we do those testing in various stages as we have children who have clots to see if there is a combined risk for them to have a clot down the road in another situation. But many of these, or several of these, we cannot test in an acute thrombotic event. So if someone is hospitalized and they've got lines and they've got a clot, there's only a few of these markers we can get. So the others are going to be, we can get those, but then we're going to have to decide what to do down the road to finish out the testing. MTHFR was a marker that was identified about 25 years ago. Dr. Paul Monagle out of Australia, who is a fabulous guy, did a lot of research down in Australia in protein S and C deficiencies, and then was working on some MTHFR studies. And what they found was that, yes, this was an identified marker, but it created a problem only in the presence of elevated homocysteine. And you can decrease homocysteine by simply taking folic acid. So he did a big study and got the folic acid to be less than 10, and then there was absolutely no risk for clotting at all. So they actually took MTHFR off the list of thrombotic evaluation tests and added homocysteine. So that there's no reason to look for this if your homocysteine is normal, because it would never create a problem. So if you've got families out there that maybe 10 or 15 years ago were giving a diagnosis that they had heterozygous or homozygous MTHFR, a simple enzyme, but now they've got normal homocysteine, they are not at risk. And it's one of the things that we do still get referrals for, because, again, a family member 10 or 15 years ago got this genetic marker, and now they're passing it along to the family saying, I want tested, we want to be evaluated for that. And it's a really important one to know that the research is very clear that if you've got normal homocysteine, which is what you should be testing for, then you won't have a problem. If you have elevated homocysteine, start them on folic acid for a couple of months and test them again. If it comes down, you don't have a problem because of MTHFR. And I got ahead of myself. So again, simple folic acid to decrease the homocysteine, it decreases your risk. So who is at risk? And this is an important study that, if you are of childbearing age, you have, again, an annual incidence of a venous thrombus embolic incidence of about 1 in 12,500 women. When we think about women who are at reproductive age, then we've got to look at our adolescent populations that many of us are taking the responsibility for, because they're kind of caught. They can't really go to the adult people yet, and many pediatricians maybe aren't comfortable with them once they've got adolescent issues. If you have a woman of childbearing age who is now on oral contraceptive pills of any kind with estrogen in them, then your risk goes up to 1 in 3,500. But look at that. If you have heterozygous, only one copy of the factor V Leiden mutation, and you get started on oral contraceptive pills, then this risk goes from 1 in 3,500 to 1 in 350. So this is the history that you need to have. If you're going to do adolescents and you're going to try to counsel them on their oral contraceptive mechanisms, then you need that really, really, really good history that makes sure that they're not going to be at risk because they've got this family history. Doesn't mean they can't take oral contraceptives, we just put them on non-estrogen. But the risk factors go way up if they do have the history of factor V Leiden mutation. Who are we going to test? If they're a pediatric patient and they have had a thrombus, they are going to get tested, because we want to look and see, was it a multifactorial, which many are, or do they have a risk once some of those other inciting factors are gone, they're going to have a risk down the road. You should do any adolescent that has a spontaneous thrombosis. And many of these, we get a lot of referral for young girls that are 14, 15, 16 years old. They're getting put on oral contraceptives, and they get a pulmonary embolism. They get a DVT. So we need to look at those young people and make sure that we do have good thrombophilia reviews on them. If you've got a neonate or a child who has now had a non-catheter-related thrombosis or a stroke, those children get worked up. But what we don't test are the neonates, the children with asymptomatic catheter-related thrombosis. We monitor those. You can do great ultrasounds. The catheter's not working too well, so they send them down, they do a dye study, and think, oh my goodness, they've got a little clot there. No symptoms, no swelling, no vascular changes in that extremity, we're not going to work them up. We take out the catheter, we monitor the kids, but they don't need the workup. And then certainly asymptomatic children. If we think that one of the biggest risk factors are any of these catheter-associated situations, look at all the children that we do put catheters in, and yet we don't recommend that you do any thrombophilia workup before you put the catheters in. So it's kind of that catch-22. We know the catheters might put them at risk, and we're using a lot more of them, but by the same token, we're not going to work up every single kid that has to have a catheter placed. So when you do look at different types of situations where you are putting PICC lines in, or Metaports in, or Broviacs in, we're not doing the workups ahead of time on that. Unless there is a strong family history, or again, they've got a personal history of having some sort of clot-associated activity prior to what you're doing. Again, we should not be testing our neonatal thrombosis. Those children have some of the biggest risk factors of all the other things going on. So most children, even if we did do the studies on that laundry list of factors, in the neonatal period, and especially if they're premature babies, they haven't developed those factors anyway. So just having them to have a protein C deficiency as a neonate is not going to be valid, because we're going to have to test them again when they're closer to a year of age. So again, getting this big workup and taking all this blood is not going to be helpful. We know that they've got small vessels, and the smaller the vessels, the more constriction and dilation creates more irritation and inflammatory response within those vessels. We have very slow flow in some of those teeny tiny vessels just because of the activities. We know they have high hemoglobin, which increases their viscosity, and we put lines in them everywhere. So unless we've got something that is going to move us beyond that, we take care of the children in the ICUs, manage their clots, and don't do their big workups on them when they are neonates. Let's go this way. Why we test or not test, there's very little opportunity to do all this testing, and it's going to do anything for that child. So the parent who comes in and says, oh, my spouse just had a stroke or had a DVT, and our doctor recommended that we get tested for thrombophilia, and we found this marker, and we want our child tested for it. That's not going to be beneficial for the child, and it may be even difficult to support the families once you have that. The incidence of venous thrombosis in otherwise healthy children, extremely low. Extremely low. So remember, going back, the biggest risk factor is going to be catheter-associated clots. So kids who are healthy and never have to have catheters are not going to be at risk. So again, testing them is not going to be very helpful. And it's not going to give us any clinical information to do anything in a child that doesn't have a clot that's going on right now. If they're asymptomatic, if they're not having any problems, then we wouldn't test them, and why give that knowledge? For the PCPs, again, that careful history is probably the most important thing for thrombophilia. We really want to make sure that you've got a good genealogy. Ask those good questions about how old are the grandparents? What's their health like? What kind of diagnoses have they had? What are the parents like? Aunts and uncles. So we want to get those first-degree relatives in there to make sure. If they do have a positive history of any of these things, an unprovoked DVT, if they've got a pulmonary embolism, if they have had a myocardial infarct and they were before the age of 40, or they had a stroke before the age of 50, those are all going to be things that are really important. And then we might want to start looking at the family history, and like I say, maybe testing family first before we start working on the children. But there is a few of those things that are going to increase our suspicion. And then getting a good history about recurrent miscarriages after 10 weeks, 10 to 14 weeks. Because we do know in some of the, especially the factor V Leiden mutations, that does lead, that's a really vulnerable period right then, after 10 to 14 weeks, where that vasculature is changing so quickly in the fetus, and if they do have some of these thrombotic changes, then that's a very common thing for them to develop a clot and ultimately the demise of that fetus. So having repeated or frequent miscarriages when they've made it through 10 weeks and then it's after that period of time is another marker that we get history for. What is this testing going to do? It's going to improve our ability to counsel so that, we can tell young people, get the family history. If we've got no family history, then you're going to be okay to go on to whatever you feel comfortable with in terms of their contraceptive choices. If they do have a positive family history, then maybe, like I said, looking at the parents a little bit more quickly before you choose estrogen-type products. Signs and symptoms of thrombosis. What are you supposed to be looking for? We do know all the stuff. You read it on the airplane. All of you came into Atlanta today and had those nice long flights. I come from California, so it was a nice long flight. You're doing your exercises. You're making sure you're getting up and moving around. You're making sure you stay hydrated. Looking for other things, avoiding that sedentary lifestyle, getting people up and moving so that they don't become obese and they don't have that increased risk with the body weight. And then certainly discouraging smoking, because those are 3 of the most important factors that then if you do have any of these thrombotic markers that are going to increase your risk. Asymptomatic children with a positive history, again, that decision has to be sat down and kind of talked through to decide. It's very difficult to give a diagnosis to a child who's had no problem just because we've got this family history, and then maybe set the parents up for looking for a problem in the child. Again, if we can test the parents first, we really prefer to do that, because that then at least gives us a little bit more idea about what we might be looking for in a child, because it's hard then to give it's easy then to give false reassurance. Oh, look, we tested for these things, but your child is not at risk. My crystal ball is just not very good. It used to be a lot better when my kids were little. I could predict anything, and they thought I was really smart. I'm not so smart anymore in that way. So giving those false reassurances and trying to tell them, oh, look, we did the testing and everything is fine, is a tough thing to do. Parents should know that, again, if they do get some sort of a thrombosis, it is multifactorial. Most children who get a clot, it's usually more related to the acquired factors rather than their hereditary factors, because they're sick, they've got extra lines in, they're dehydrated. We've got all of those factors that come into play way more than we've got an opportunity that this is a genetic predisposition that put them at risk. Parents should know that, we can do the testing, but it's not going to change what we do if we have to manage a clot. And as I mentioned earlier, some of the factors we can't even test because they get consumed in a clot, so we can't even prove anything until after we've managed the clot, got them well beyond that period of time, and then they're ready to move on. Our testing is still limited. Like I said, we gave diagnoses of thrombophilia to people who had a heterozygous MTHFR 15 years ago, and now we've learned a lot more about that, and we're trying to now disabuse that diagnosis and take it away. And, sometimes families have to hold on to a diagnosis thinking, oh my gosh, this is really important that I know this particular information. And then again, the negative results may give a false reassurance that they're not going to be at risk and our testing is not perfect. Again, the benefits, like I mentioned before, are going to be for your adolescents. And those are the ones that you want to do the really, really good histories. Like I said, we've had many young girls that were referred into us because they got started on oral contraceptives without taking a really good history and then developed a pulmonary embolism or developed a DVT. So that is probably going to be the best place when you're dealing with your adolescents, is giving that good history. If we've got thrombophilia, again, you've got to avoid the estrogen-containing hormones. You need to avoid obesity. You need to avoid smoking. And we need to avoid immobility. Along with that, we do consider anticoagulation if the immobility is unavoidable. For instance, in this little picture, we've got external fixation for a major fracture. They're going to be relatively immobilized, and if they did have any sort of clotting activities, those kids we would usually put on Lovenox. But for an average variety person who doesn't have to just be down for extended periods of time, they're not going to need anything like that. So jumping quickly to sickle cell disease, and again, I'm going to go through this one relatively quickly and try to get to you some of the treatment things and what you're going to see in your primary care practice. We know that it's a beta chain defect with hemoglobin S. It's autosomal recessive, so each of the parents are going to be having that particular opportunity. You got our good old Punnett squares there that you can go back in basic 7th grade biology. But I think what's really important is to think about our populations today. If you look at this particular map, and you're going to see it again for thalassemia, but look at where we've got the green. Sickle cell anemia classically was a sub-Saharan African diagnosis because of malaria. Malaria likes to live inside host red blood cells, but it only likes healthy red blood cells. So anyone who was sickle cell trait or had sickle cell disease in sub-Saharan Africa when they used to have malaria outbreaks, they would live, and the people with normal red blood cells would die of malaria. But now look where we've got all of those green patches, all around the Mediterranean. One of the biggest research centers for sickle cell disease is in Saudi Arabia, over into the middle of India. So we have a multicultural diagnosis now that is really expanding in our populations. And so being able to recognize where it is that we're seeing these different genetic changes coming from is important to look globally. This is an in vivo picture of normal red blood cells, nice, fat, chubby, discoid, wonderful. This is a slide, a smear, where sickle cell was diagnosed and given the name sickle cell because when you take that live cell and you kill it and you put it on a slide and you smear it out there and you look at it in the microscope, it's a red cell membrane disorder and the membrane collapses, giving a classic sort of sickle-type presentation. That's what a dead cell looks like. This is what a live in vivo sickle cell looks like. Again, this is what the image I want you to take home, because when we've got children who have sickle cell disease, this is what's going on trying to go through the microcapillaries of those vascular beds, and like a set of jacks running down a tube, they're going to get clogged up. These cells can morph in and out of this asteroid type of fixation up to 12 times before that cell is usually going to be taken out of the system. So when we get into those situations, it kind of gives you a better appreciation than that simple little sickle cell that's on a slide, to think that this is what's running through those microcapillaries. The natural history, the children are born, they're usually normal weight. We do get it picked up on newborn screening since 1983, so they will be identified with sickle cell trait or sickle cell disease on their newborn screening, which goes back to their primary care, usually within the first 2 weeks of life. The first month, very rarely do the children have any problems at all. But then after that, as they're growing, as they're going through their normal development, now we begin to see some mild anemia because those cells are morphing in and out of that. Because it's a red cell membrane, they are a little bit more fragile. So they may begin to become a little anemic. Hand and foot syndrome at 3 to 6 months of age, where again, you think about those microcapillaries way out into their little fingers and toes, and they start getting clogged up, and then they create that inflammatory response, and they get that extra edema that's going on. And the babies can't tell you, but now they don't want to move, and they don't want to make a fist. The splenic enlargement begins because now your spleen is your garbage disposal. It's trying to take out all these abnormal cells, so it becomes enlarged. What else is a spleen? A very rich vascular bed. So now we've got these same microvascular access problems going on as those sickle cells are clumping up in there and being taken out of circulation, so that these children basically autosplenectomize themselves by 2 years of age. Their sequestration crisis, again, if I start seeing all of these cells and they're morphing in and out of these, then the spleen wants to start taking them out. The spleen can just start trapping all of their blood, and their spleen gets very, very large. 6 years to puberty, again, we still have vaso-occlusive, where we've got trying to go through those large vascular beds. In the abdomen, vascular beds. In the large muscles of the legs. So you've got leg pain, you've got abdominal pain, you've got back pain, any place that you can think that you've got those vascular resources and you've got those little asteroids going through it. And then osteonecrosis that begins at a very, very early age. The other place we've got a very rich vascular bed in children is at their growth plates. And so if we are blocking off those, again, those microvascular little vaso-occlusive episodes, then they begin to kill off their bones and they start developing osteonecrosis at a very early age. The second decade, from 10 to 20, now we've got children who are having microvascular disease. They may be having little strokes. And not big ones that you would ever know about, but might be having enough to where we've really got to be watching their schooling, making sure that they're staying on grade, making sure that they are having the opportunity to really keep up and we're not having difficulty. If we did routine cerebral MRIs, we would see that we begin to see some atrophy because, again, that microvascular area begins to kind of clot off little areas that don't create a big, oh my goodness, you've had a stroke, but they may be losing function. And then, of course, priapism fits in. Again, in the penis, a very rich vascular supply as they now are coming into that peripubertal, prepubertal, into puberty, priapism where they get that very, very painful erection. And again, if you're a 12-year-old, it's going to be very difficult to let somebody know, but it's a very significant problem in a medical emergency. The third decade now, we begin to see renal insufficiency. We begin to see pulmonary failure because, again, look where your rich vascular pools are that may be being insulted time and time again because of what's going on. And then we get that the osteonecrosis may become debilitating to where they need a hip replacement in late 20s or early 30s, and then retinopathies. Mortality in the first 10 years of life, 1.1 per 100 person years, which is about 10 times what it is in the regular population, about 1 per 1,000. So we have a really important opportunity to watch these kids very closely. What do we do when they're diagnosed as hemoglobin SS, the homozygous hemoglobin S disease? Those children will very often get put on transfusion programs after they've had their first true episode of some sort of a vaso-occlusive problem. We start the children now on hydroxyurea, which has been used in the adults for years and years and years at 9 months of age to try to increase the percent of hemoglobin F, their fetal protective hemoglobin, and decrease their percent of S, the sickle cell hemoglobin that's creating the problems. If they have to go on to transfusions, that's a simple way to, again, shift those balances, decrease the percent of circulating sickle cells, but with that, we're creating an iron overload situation because they're chronically anemic and we're giving them nice, healthy adult red cells that have been donated. The body wants to store that iron someplace, thinking I'm going to use it down the road. So they store it in their heart, in their lungs, in their liver. And we need to be aware of that and then begin our chelation programs. Because they are asplenic very quickly in life and we don't actually measure when that is, we just know that if they're untreated and they are a severe diagnosis, they will lose their spleen themselves. It will clot off by about 2 years of age. They do need to be started on their penicillin. The recommendations out of the National Sickle Cell Foundation are that they should be started by 2 months of age. They continue until they're 5 years of age, and then if they've got their immunizations all up to date and they've had no problems, then we can take them off of their prophylactic penicillin. There has been absolutely no reports of penicillin resistance on the children who have been started on prophylactic penicillin at these very young ages, and I have argued with healthcare providers in the community who say that I am creating resistant organisms by putting these children on penicillin, and again, the National Sickle Cell Foundation has done a lot of research and has found that that is not the case. We know that pain is one of the hallmarks of sickle cell disease, and again, it comes out in lots of different ways. One study, and again, this was on adult populations, but they found that 70% had frequent or occasional pain, with only 30% complaining of very rare episodes. And yet the highest rates were in the 19 to 39-year-olds. So this is on an adult population that has this large amount of pain. If we can translate that down into our children and try to figure out how many of them are having it and don't get believed, don't have the opportunity to express it in a way that's going to be believable. Mortality correlates directly with pain. The more pain you have, the more risk you have of mortality. So recognizing this early, and that's why we now are starting the children on hydroxyurea at a very young age. What can we do? Avoid illness, because again, that changes the osmolality, it changes the viscosity, creates that inflammatory responses. Give them their immunizations, especially their pneumovax and meningococcal vaccines. When we got those for the little kids, it was like magic. Because previously, if you remember before Prevnar, we didn't have a pneumococcal vaccine that they could use in the young kids. We had to wait till they were 5. So giving those immunizations is wonderful. Hand washing is probably the best, teaching the families very early how to prevent infections. Make sure that they're hydrated, teaching the little ones that they need to drink fluids and be quantitative about it. I want my little ones, they come in with a water bottle, or more likely a Gatorade bottle. Okay, throw out the Gatorade, and I want them to have 2 bottles filled up with water every day. so that they make sure that they know exactly how much water they need to keep hydrated. And then avoiding extreme temperature changes. In California, we're having kind of an early spring. We've had a little bit of rain. We've had a couple of warm days. And in the next couple of weeks, we are going to be seeing these children who now it's 80 degrees in the daytime. And so what do? They go out and they jump into a cold swimming pool. And then they get out into the warm sun, and the next day they're in clinic in pain. Or they're calling in the office because now they've created that vascular constriction and dilation from jumping in and out of hot and cold places. So if we can teach them how to make sure that they're not the first ones in those springtime pools, and making sure that they do stay warm if they're in very cold climates, wearing their gloves and their hats, it's very important. Pain management, we can certainly do it when they're hospitalized with IVs, but for home, we do like using NSAIDs in proper doses and making sure that they understand, making sure that they have those at school. We have letters that go to school that say, go to the nurse's station, we've got their medication, give them their dose, rest for 20 minutes, give them some fluid, and send them back to class if they're doing okay. If they're not, then call their parent and get them home. But they don't have to use that to get out every single time, and yet we need to recognize that they may be in pain. We do not recommend that narcotics go to school. If they think that they need something stronger, then they need to be at home. They need to be somewhere where they're being managed. Fever is an emergency in these children, and that's a temperature of 101.5 or more, and the parents, of course, need to be identified if they're of school age. Lots of things associated with the psychosocial aspects of sickle cell disease, such as the genetic, family planning type things. Very unpredictable course. We, again, don't have the crystal ball. We can anticipate what might be going on, but each child is different. Again, African Americans, which is a known population for sickle cell disease, live with a lot of other stressors. Other populations, I'm in a very rich Hispanic area, and we've got the vast majority of our sickle cell patients in my particular practice are Hispanic or Middle Eastern and East Indian, because we have very large populations there, and they're shocked. We shouldn't have this in our family. And you saw that map that shows that, yes, we have a very identified areas where you will be having these genetic pools. And then the pain that we know impacts a lot of different things. Adolescents often have a lot of issues because they do have delayed growth. They're chronically anemic. They have delayed onset of puberty because of their chronic anemia. So now you've got, a 13-year-old boy that looks like, a 10-year-old. We don't start hormone recommendations for growth delays on the boys. Our endocrinologists recommend that after 17, for the girls after 15. So they really try to let them maximize their natural growth as much as possible, and that can create some problems. Thalassemia is very similar to sickle cell, except we've got a little bit genetic boost that's different. Again, over 60 known mutations, and we're getting more and more research into those mutations as our populations change. It is identified again on newborn screening, so that we will find children who have either alpha or beta thalassemia on newborn screening. The alpha gene is producing hemoglobin in the fetal population, so an alpha defect will be noted as anemia right at birth. The beta gene doesn't really come in until about 3 to 6 months of age, so they don't get their anemia problems until they're a little bit older. Again, we go through a little bit of the genetics there for both the alpha and the beta. But look at the populations again. All across that big swath, that yellow swath, all across the Mediterranean. Both the northern and the southern Mediterranean populations, all across the Middle East, all into India, down into Southeast Asia. Also in combination with that, if you look at hemoglobin E, because hemoglobin E beta thalassemia, in California, we have one of the highest populations in the Southeast Asian people. And so we see a lot of hemoglobin E beta thalassemia. It's come from those areas. Again, because it's a genetic code that tells them to make a very, very microcytic, a very small cell, they try to compensate by making more, so they have high RBCs, but they have a chronic anemia. So consequently, our goal is to try to keep their hemoglobin over 10. But we don't keep it much over 10 because we know we can't do that over time for a long period of time. We want to maximize their growth as much as we can. But some of the alpha thalassemia kids, they may do fine with a hemoglobin of 7 or 8. So again, into your practices when they come in and you know you've got this diagnosis, and you're doing your routine hemoglobin checks on your health maintenance, then you know that that's because of their thalassemia, and you're not going to start them on their iron. You're not going to do a lot of interventions. Sometimes, because again, these cells are very abnormal and your garbage disposal, your spleen wants to take them out of circulation, they will get a very, very large spleen. We don't recommend splenectomy until they're greater than 5 years of age. And even then, we try to kind of put that off a little bit to see if we can balance a few other things. But after 5 years of age, if they've got a very, very enlarged spleen and they're an active kid, then they're at risk for splenic trauma, and that can be life-threatening. So many of these children will get a splenectomy after age 5 if it's been very, very enlarged, and that's continuing to take out their cells and creating an imbalance in their ability to maintain their hemoglobins. And then once we take out their spleen, they get prophylactic penicillin until they go to college. We choose college just because by then their immune system is matured. Most of them won't take it anymore after that, but they still have to make sure that they seek care if they do get a febrile illness. Oops, I went too fast there. Oh. Again, treatment programs, we do have children who are going to transplant if they have matched siblings, as bone marrow transplant has gotten so much better. But it's not a priority for bed space, so a lot of the children are just managed medically. We do give them some folic acid because they're turning over cells because of the destructive process, and we caution them with our dietitians to not have extra iron in the diet. How often do you get to sell that to a little kid? You know, don't give them iron. Usually we're just the opposite on that. Long-term goals is, again, helping schools and families understand these kids that are running low hemoglobins. They're not going to run the time mile at school like everybody else. They may be a little bit, a little bit more tired, and we have to just be cognizant of that. Watching their growth and development so that we do maximize it along the way as much as possible. But again, these kids with chronic anemia are going to have delayed sexual maturation, so helping them deal with that and coping with those changes. Got some references for you there, and then I want to go into hemophilia. The two big ones are hemophilia A and hemophilia B. They are both X-linked recessive, which means that the mother is the carrier and will pass on the gene, but remember that the father is the one that determines if it's a boy or a girl and allows that gene to be expressed. So I'm an equal opportunity guilt monger. You know, you're not blaming one for everything because it takes two to tango. And we have a lot of discussions about that with our families. Von Willebrand's disease is an autosomal defect, and I'm going to go into that one in just a second. So again, I kind of went through this just a little bit to see if we've got carriers or not. With hemophilia, it is graded out as 3 different levels. So you've got your mild, your moderate, and your severe. The severes are the children that have less than 1%, so they are going to have spontaneous bleeding, and it's usually into the joints. The milds are going to be 1 to 5%, and generally, they do pretty well. They may have, a little bit bigger injury with a trauma, but they don't usually have spontaneous injury. And then the milds that are greater than 5%, we often don't even diagnose those until they're a little bit older. We had one young man that was 15 that we diagnosed. He was a freshman quarterback. He'd had this knee that was kind of bothering him. They were resting it, icing it, taking care of it, and it finally just didn't quite get better, and so they sent them into the orthopods to have it tapped to see what was going on. So our orthopedic surgeon tapped it and pulled out blood and said, oh, no. So you're not my problem. You're going across the way to hematology. And he had 15%. So he was a mild hemophilia that was 15 years old playing football. But because he was a very, athletically skilled young man, he was a quarterback, so he was kind of protected, and he made it all that way. And then we told him he couldn't play football. Eek! Whole nother thing. Most bleeding episodes in severe hemophilia are going to be intra-articular, so it's going to be within the joint space. And again, not many countries have access to factor the way we have access to factor in this country. And so when you've got a bleed like this, where it just continues to ooze and bleed on top of itself, over time you're going to completely destroy that joint, as you can see in the cartoon drawing that's there. For school or for injury, when they call your office and say, oh my gosh, they just fell down at school, what do I need to do? Again, you treat them the same as any other student. If that was an injury that you would call 911 on, you know, somebody accidentally got hit in the head with a baseball bat, then you would do that for this child also. If you can get into your mind that they're not going to bleed faster, they're not going to bleed out, it's just going to ooze for a longer period of time. And so you've got to start recognizing it and take care of it, because otherwise, we have them all the time, they'll call and say, well, he must have done it yesterday because I didn't say anything, but he woke up this morning with a big swollen elbow. Because it oozed all night long because it wasn't recognized that there was some trauma there. Factor infusions, they're only given IV right now, although they are looking at some oral preparations, but they're kind of futuristic. It's going to be down the road. It's all recombinant now, which means it's all manufactured. None of it is from human plasma. So the risk of transmitting any of the HIV or hepatitis type things is completely gone in our population now. We teach the kids about age 8 to self-infuse so that they get the big stick award when they go up to hemophilia camp. The factor is very expensive. It's about $1 a unit, and we dose them at about, on average, 50 units per kilogram. So a 10-kilo, 1-year-old with severe hemophilia who's now walking, we're putting them on a prophylaxis program 2 to 3 times a week. 50 units times 10 kilos, 500 units 2 to 3 times a week. That's now going to only get more as he goes through his life, because we can replace and make him a normal kid so he saves his joints, but it's going to be an ongoing process right now. Pain management, again, joint bleeds are painful, as you can imagine, that intra-articular. We teach our teenagers at the first tinge, at the first little cringe that you get that something's going on inside there. It feels hot, it doesn't feel right. Then that's where you may need an extra dose of factor. That's where you need to rest and ice it, because you don't want that to progress. We do use acetaminophen with codeine, but of course we avoid all the NSAIDs that would be inhibiting any platelet activity, and they've already got one bleeding problem, so we don't want to add another. And then we use a lot of rice for the kids. And that's one of the first things that they get to tell us if they know about their disease process. Do they know what rice is? Long-term goals, we want to avoid joint contractures and avoiding the trauma. We do recommend self-limiting PE, which means that, you know, they may be missing a lot of PE activities, and each school district is kind of different on what they require. We do avoid contact sports, and so that means wrestling and American football are the two biggies that we take the kids out of, and it can create a lot of problems. But we say you can play baseball, just don't be the catcher. You know, where somebody's going to run into you and it's hard on your knees. You can play soccer, don't be the goalie. You can play basketball. You know, we try to give them all the things they can do and limit just those few things that they can't. Again, the prophylaxis programs we start on very, very quickly, usually by 1 year of age once they start crawling and walking, because they're going to be at risk for joint problems at that time. Their life expectancy now is normal. Because it's all recombinant, we're not giving any sort of increased risks. And again, short of not having a head bleed in their neonatal period, which again, if we know to expect this, we can prevent that also, they have a normal life expectancy. Von Willebrand's disease is actually the most common bleeding disorder in the world. The clinical signs for this are epistaxis, easy bruising, spontaneous ecchymosis, and menorrhagia. So we're not seeing the joint problems that we see in hemophilia. It's a slightly different activity that's going on. It is an autosomal inheritance, and the incidence in the world is 1 in 100. So, you know, we've got a little more than 100 people in here, but we could probably go around and find a couple people with von Willebrand's right here. Again, because it is symptomatic type problems, most people will not be diagnosed as very, very small. They may be diagnosed when they have a tooth extraction as a small child, or maybe not until they're an adolescent and getting their wisdom teeth extracted. We often will diagnose the girls when they begin to start their periods and they're having horrendous menorrhagia that they can't quite get organized to take care of. And each of those things, again, go back to history, because a lot of times we've got this in the families, it's genetic, But the moms all say, oh yeah, my sister and I had heavy periods too, but that's just what we were, so we didn't even think about that. So it's then going back and testing the mom, testing, testing for the aunt so we can build this picture. When we do have a problem, we do have different things that we can use. Desmopressin, DDAVP, is the active medication in either IV solution or in a Stimate nasal spray. It actually stimulates the release of factor VIII that carries the von Willebrand's factor to help create a clot. So when we've got somebody who's got a nosebleed, we can use Stimate or we can use DDAVP. If we have to have extractions, again, we can use those ahead of time to make their clotting system normal for a short period of time so they can get through a minor procedure. Humate-P actually is measured in ristocetin cofactor units for von Willebrand, so we can use that as a total factor replacement should someone have major trauma or have to have an extensive surgical procedure. And then epistaxis care is so important because we know kids have nosebleeds and it gets kind of creepy when they're throwing up blood because they've been swallowing it, or if they're pinching their nose right and then they start kind of getting blood out their eyeballs because it comes right out the lacrimal glands and it kind of makes people a little freaky. But if you're doing it right and you're leaning forward and you're truly pinching your nose, and I do like this for the kids, and I said, I want you to talk like me and this is how you take care of your nose, then they'll begin to learn how to take care of this and again, make sure that they can get their nosebleed stopped and take care of themselves. I have a few more references. Allaboutbleeding.com is a really great one that has a lot of good von Willebrand's information, and it's a good one that I give to my families, and it comes in multiple languages. I want to talk just a little bit about ITP, autoimmune thrombocytopenia purpura. If you were in the luncheon one where it's talking like 58% of us have been doing this for 17 years or more, I don't know where they got 17 was the magic number, but if you've been doing this a long time, this used to be called idiopathic thrombocytopenia purpura because, again, in the olden days, idiots didn't know what caused it. Now we know it's an autoimmune process. It's post-viral destruction. The viruses that go in and are being stimulated to have an immune link to the host cell to destroy that cell and get rid of the virus, the immune system in immature children just continues to now look for something, and the protein on platelets is very similar to the protein that is altered in a host cell when a viral cell gets inside it. So it begins to then attach to the platelets once it's gotten rid of all those viral cells. You can have acute ones, which last usually less than 1 year and completely resolve themselves, and then you go into a chronic situation. A diagnosis for this is when you've got a platelet count less than 150,000, with the normal being 150 to 450,000. These are epistaxis. It's difficult to control, even with all of the good things that I was talking about on how to control a nosebleed. Greater than 20 minutes is what we consider, and that's truly sitting down, pinching their nose, doing quiet activities, sucking on ice or a popsicle, and making sure that you are doing everything to try to stop that nosebleed. These kids, even if you get it stopped for a short period of time, there's less amount of von Willebrand's factor that is making that platelet aggregation, and so the clot is very soft and fragile. It often falls off within a few hours and they start to bleed again. So that's another marker. Increased bruising or petechiae is another thing. Again, petechiae that look like this, like a huge red rash all over because they're just popping out like crazy. And then gum and mouth bleeding in children that don't have severe disease, gum disease. We treat them with lots of different things. If you're familiar with George Buchanan, he's a hematologist out of Dallas, and he would recommend tincture of thyme all the time. Again, about 85% of these kids, they're self-limiting. It's going to get better within that year, but they might have to just, oh, I've got one here, thanks. I know, it's just trying to talk so fast. And I got that airplane circulation stuff that got me the other day. So tincture of thyme might be something that we do, and we would do that if their platelets are greater than 10 and they are perhaps a school-age child. With the little ones or anybody under 10 or with active bleeding, they all get treated. And then the treatment may be anything from corticosteroids. We use both a high-dose dexamethasone and prednisone for short courses, IVIG, intravenous immune globulin, and Winro, which is an anti-D type thing that takes out the particular immune component. Again, most of these kids, 85%, are going to get better, perhaps with 1 dose or 2 doses of IVIG or 1 intervention with one of the corticosteroids. And then they're not going to have problems. Again, the one caveat is if you've got a dose of IVIG, you need to delay immunizations for at least 2 months because that immune globulin effect will decrease the effect of any immunizations that have been going on. And they should not get live viruses for 6 months after IVIG. Chronic diagnosis that lasts longer than a year, again, we monitor those kids, and usually those are going to be the teenagers. They're not going to be your 2-year-olds that just have an immature immune system. These are going to be the bigger kids that now we're probably going to do a lot more immune workup on them to see if we've got something else that has caused this dysregulation in their immune processes, and they're continuing to put out these immune markers that are taking out their platelets. Hereditary spherocytosis is another one of the blood dyscrasias that you'll see back into your family practice or into your primary practices once the family has been educated about the disease process. It is autosomal dominant, so if mom or dad have it, then they have a 50-50 chance of giving it to one of their children. It's the cell shape that's different. You see this in the MCHC when you're looking at your CBC because it will be high. Because instead of being that nice little discoid, it's very spherical, it's very round. And so consequently, it packs in more hemoglobin. So your mean hemoglobin concentration is going to be a little bit higher. And that can be diagnostic for HS. Again, if we've got an affected person, it's got your wonderful Punnett square there cartoon. But these kids in primary practice and for school age are the things that you need to know about. And you need to be able to do good exams because, again, they can get quite a bit of splenic enlargement because the spleen wants to take out these abnormal cells. They may have chronic cell destruction so that they run bilirubins that are in the 2, 4, 6s. So they're chronically looking yellow. And we've had referrals from schools into hematology or to the parents, and then they get sent to hematology because they think they've got hepatitis. It's a very different jaundice color when you've got this particular one, but again, it helps us make the diagnosis sometimes. They may be anemic depending on how severe or how fragile their cells are, and so we're monitoring that. Again, we wait until they're at least 5 years of age to take out their spleen, but if they're having to have transfusions because of the cell destruction that they're seeing, because of their severe cell shape changes, we do recommend that they take out their spleen by 5 years of age. They go on their prophylactic penicillin then, but you take out their spleen. No, actually, as soon as they tie off that splenic artery, they stop destroying those cells and their hemoglobin goes back up to normal, and they still have spherocytes, but they're not being taken out of circulation. So they've still got the disease, they can still pass on the disease, but we can take away some of the symptomatology and maximize their growth. Once they've had their spleen out, then certainly fever is still an emergency. And finally, pediatric cancer. Oh, water's so wonderful. How prevalent is pediatric cancer? And the thing to put this up for you guys is because, yeah, they're going to go to subspecialty to get their cancer treatment, but because of some of the slides I'll show in a minute and the wonderful advances in treatment, these kids are now living very, very long, full lives, and they're coming back to your practices and they've had this diagnosis. The National Children's Cancer Foundation has found their latest study that 1 in every 33 children in the United States will be diagnosed with cancer by age 19. It's an incredible amount of childhood cancer. About 80 to 100 new cases of pediatric cancer each year in Central California. I'm at Valley Children's Hospital, which is right in the middle of the state. We serve about 7 counties, and we had 128 new diagnoses last year. But we've got a really rich pool of population to draw from, but it's been pretty steady. Common presenting symptoms, and this is one thing, again, if we get a new diagnosis, very often the referring primary care practice is, oh my gosh, what did I miss? What did I miss? You know, should I have gotten this sooner? Look at the list of presenting symptoms. Fatigue, irritability, loss of appetite, nosebleeds, fever, febrile illness, a little infection. Look at your pediatric population. You see this every day. So when do you click over and say, oh my gosh, this might be something that's more than what I would have anticipated before? When you get in the bottom, those are the ones that should. You know, bone pain that stops the little ones from walking, that should get somebody's attention just a little bit. Certainly headaches in children, we know that that's a marker we should pay attention to. Repeated vomiting or weight loss that's associated with vomiting disorders, and then sometimes it's even just the sports injuries that are out of the norm for an otherwise active kid. But again, one thing I want to reassure, and that we do this with the primary care when we send our letters back, is that you didn't miss anything. You did all the right things that you were probably supposed to do based on whatever those presenting symptoms are, because again, it's a laundry list of every single kid that you see in your practice. A little bit busy, I've got another one that's busy too, but again, childhood cancer rates, leukemia is still the most common childhood cancer, then followed by CNS and brain tumors. I'm going to show you a slide a little bit on our advances that we've done in terms of treatment and event-free long-term survival. This one breaks it down by the under 14 years and the over 14 years when we're still looking at basically our pediatric populations. Again, leukemia for the under 14 years is still the most common childhood cancer. But if you look at the bigger kids, now leukemia becomes less of the pie, and now we've got things like carcinomas and melanomas and lymphomas that we don't see in the really small kids. So you have to kind of put your hat on a little bit differently depending on the age of your child. We know the differences between adults and kids, well studied, well documented. So kids are going to have leukemia, brain tumors, and a few of the others that were on there, whereas adults, lung, breast, and colon cancer. Luckily, we haven't seen that yet in kids, so we've got very different populations and very different things that we're dealing with. This is a study that if you begin to look at where we were and where we are, and I hope that you can take a chance to look at this a little bit more closely, but if you look in the 1950s or 60s, if you knew anybody that was diagnosed with any childhood cancer, you know, I'm a good little Irish girl, and so everybody went to church and just lit a candle because you know they were going to die. Whereas now, if you look at, and this study is just out of 2010 and goes up to about, 2000 goes up to about 2010, we've got long-term event-free survivals that are in the 90 percentiles on some of these childhood cancers. So Hodgkin's lymphoma is that top yellow one up there. So we know, again, the lymphoma is in the 14 to 19-year-olds, but when we diagnose that and treat that, these kids are living, 90% of them are doing really, really well. Acute lymphoblastic leukemia is kind of the bright green one there, and again, it's up into the 90% event-free long-term survivors. So these kids are diagnosed in leukemia between the ages of 2 and 10, getting their treatment, and then they're living long, full lives. Now, treatment is going to take place in your specialty center, so you're going to have them out of your practice for a couple of years while they get their treatment. They do an induction, they do a consolidation, we do a delayed intensification. It's different evidence-based studies that show that we're getting these good outcomes. And then they go into maintenance, with the males getting 32 months of maintenance chemotherapy and the females getting 20 months. And it's all because of those little testicles. They did the first studies where they were treating the children at the same time, and they would stop their chemotherapy and then continue their follow-up, and the boys would have secondary relapses, and they would have testicular masses. So the body is trying so hard to preserve that potential to procreate that it was clear that the chemotherapy needed to continue a little bit more to make sure that we weren't having leukemic cells that were hanging out in the testicles and then being able to rear their ugly heads as soon as we stop the chemo. So the boys do get a year longer. Long-term issues for these children, because we do know that they are going to be out for a little bit and then they have to be integrated back into their schools and their societies, is we do watch their growth charts very, very closely. They often are referred and evaluated by endocrine to make sure that they are maximizing their growth. We look for hypothyroidism, which again, the evidence has shown it is a result of some of the chemotherapy products. We consider growth hormone and hormone replacement when we look at these kids and are monitoring, and we do that in consultation with our endocrine colleagues. And then if they do have to have radiation, especially any of the bone tumors or some of the solid tumors, those radiation fields may have a lack of growth, and so they're monitoring that. The radiation protocols are so much better now that we don't see nearly the external or extracurricular tissue damage that we used to see, and that they can focus those radiation fields so much better. Long-term things that we think about, certainly is school and learning. These kids are out of school maybe for 2 years, 3 years, depending on what's going on. If they are stable in that 20 or 32-month maintenance program, then they can go back to school with just certain caveats about watching for febrile infections and that sort of thing. It just kind of depends on your populations. Sometimes the children do have to have a special IEP to make sure that they do get caught up and they do have an understanding that they may need some special support. We try to do neuropsych testing before they start their chemotherapy, and then we do neuropsych testing following so that we can make sure if we've got any gaps depending on what type of problems they may have. Now, certainly the brain tumor kids are going to have a more closely watched protocols than, say, a leukemic kid that's not getting any CNS chemotherapy or anything, but we do monitor them very closely. Looking for hearing loss, because we do know that several of chemotherapeutic drugs that are the recommended drugs for these treatment protocols can damage their hearing, so they're monitored carefully on that. And then we get them back in for self-limiting PE, and I write a lot of those scripts, and I would like you to in primary practice also, because the kids want to be where the other kids are. And especially when you get into some of the later elementary school and junior high, that's like their only sort of free time. And I'll have the kids all the time who say, oh no, I don't want to get out of PE, I want to go to PE. Well, you get the ones who want out too, but you know, a lot of the kids who've already missed some of that socialization, they want to go to PE, they want to be involved. And so we do try to get them self-limiting PE type opportunities so that we can make sure that they can do everything that they want to do. So I would really like you to live long, love well, and laugh often. I've got some really nice references that are really too small to read on that slide, but you can pick them up and get them there. And you can contact me if you do have any questions or have any questions you want today. We got about 6 minutes. Sure. Okay, the question was in ITP, how does the IVIG and the steroids stop the process? Again, what it does is it turns off that intrinsic immune response that keeps going out and tagging the platelets, and it just calms it down, turns it off, so that now you've got plenty of circulating immune globulin, so it stops producing it. The thing about that is sometimes we have to repeat that a month or two later, because once the IVIG wears off in 2 to 4 weeks, their counts start dropping, so we know that they've still got a strong response. But again, that's why we give them 6 months to a year to be completely over it. Same with the steroids. It's an anti-inflammatory that cuts off that intrinsic process and stops them from putting out the marker. Hopefully, once it's turned off, it won't turn back on. Other questions? Yes? Oh yeah, I'd love it. The question was, what's the dose for the post-splenectomy penicillin, and can the PCP do it? Absolutely. In fact, I had one of the school-based clinics that the nurse practitioner there would, I got your kids in here, you know, they're out of penicillin and folic acid. You want me to give them some? Absolutely. So if they are over 3 years of age, it's 250 milligrams PO BID. And again, since for the sickle cell babies that we start them on at 2 months, we do 125 BID until they're 3, and then they turn them over to 250 BID. At least until 5, and they have to show good titers to meningococcal and pneumococcal organisms, because those are the 2 encapsulated organisms that once you don't have your spleen, they're going to put you at risk for overwhelming sepsis. So thank God for pneumococcal and meningococcal vaccines. But check their titers. Yes? I couldn't The correlation between MTHFR and nitrous? And undergoing surgery. Again, MTHFR is taken completely out of our thrombophilia as long as their homocysteine is okay. So I'm not familiar in using that to, yeah, I can't really answer that one because I'm sorry, got me on that one. Yep. In sickle cell, are we seeing a lot of asthma looking like acute chest syndrome or overlap in that way? I'm from the Central Valley where we have a huge asthma problem in the whole Central Valley because of the dry air and the dust and the molds and the pollens that are there. So in sickle cell, if they are homozygous SS, almost any other combination, we rarely see acute chest syndrome. So let's put that out there first. So they've got to go homozygous SS. Those kids, if they do have asthma and they come in with any sort of thing, they get on hematology service instead of on the residents or anybody else's service because they want to treat them as an asthma exacerbation as opposed to acute chest, and we treat them as acute chest until proven otherwise. So yeah, is there a correlation? Most definitely. But it's knowing how they're responding, what their symptoms are, and then treating them for acute chest instead of trying to do asthma management and then, oh, it's not working, and then realizing they've got acute chest. And again, we're not seeing as much as that because we're putting them on hydroxyurea so early. So that increase of fetal hemoglobin has really decreased our acute chest admissions. It's good stuff. You can get them to take it. Yes? Right. Yeah. Right. And you know what? Asking a question. And the other thing, if you're concerned or you've got an abnormal CBC or you've got a lump that you don't know about, you don't have to wait for insurance to give you approval to be seen. Those are direct referrals to a hem-onc center. Yeah, so that's another. She was just saying how, do your good assessment, trust yourself. And keep those red flags up there because they're going to show up like every other kid. But if you're doing your due diligence, you're going to pick these things up, and don't beat yourself up because if it's leukemia, it's a slow and insidious process. It didn't happen today and now it's worse tomorrow. This has happened over weeks. And if they do have a fever and their ear does look red, treat them. And then when they don't get better or when that fever persists, then get a CBC. We don't do as many, CBC is a kind of easy thing to do and a big, easy marker to just say, whoa, this doesn't quite look right. And the other one is your adolescence. Oh my goodness. Okay, so testicular cancer, again, 15 to 25-year-olds are the highest incidence of that. And again, how many 15-year-olds are going to say, hey, take a look at this. It looks a little big to me. No, when it's the size of a grapefruit or a softball, then they're letting somebody take a look. And you're right. Cure is remarkable if we get them early. Yeah. The question is, do we do routine testing for von Willebrand? So mom knows that she's got von Willebrand's disease and now she's got a 1-year-old, 1 month old. Would we do testing on a 1-month-old? Absolutely not. When they're closer to a year, we may. But it would depend on if we are seeing symptoms. Now remember what the symptomatology is. So they've got gum bleeding, well they're breaking through teeth. So what's the quality of that bleeding? Bruising, well they're learning to walk. So we're looking at that, and if we see it more, then we might test it a year, but many times we will wait, because the problem with von Willebrand's testing is it's an emotional reactant. It's a fight or flight response. So if you get a 2-year-old that you're trying to do testing on, a blood test coming at them with a needle, and they don't like it and they start screaming, they instantly raise their von Willebrand's levels as to protect them. So if they're just a very mild von Willebrand's, we won't pick them up. So we won't test them until later, and we've got more symptomatology, even if we've got a positive family history. So we watch that really, really carefully, and then try to get them when they're a little bit older, because if they start screaming, we're not going to get good testing anyway. And the comment was he was 32 years old, an incidental finding for von Willebrand's. Again, the vast majority, when you look at those statistics, 1 in 100 people, they don't even know it. You know, and the ones that do, it's probably less than that. But again, it's a guy who's got von Willebrand's, he's got nosebleeds. Well, he's a big, tough guy. He doesn't have a bleeding disorder. So the women get picked up because of childbirth and because of menorrhagia. But guys can go, and then we make the diagnosis, and they're looking at them, well, I don't have a bleeding problem. Look at me, I'm tough. So, yeah. I thought there was a hand up, yeah? I'm sorry, one more time? Okay, we pick it up on newborn screening, but they don't have the anemia problem until they're closer to 3 to 6 months of age. So we can find it on newborn screening, it will come out, but then we just monitor them, and they're not going to need a transfusion. Hemoglobin, thalassemia, beta thalassemia is a blood product dependent disorder if they've got thalassemia major, so they won't need to have transfusions until they're greater than about 6 months of age. So that's because they've still got their alpha that's giving them some hemoglobin, and it's not until they're 3 to 6 months age, and now they've got the defect in the B chain and it's not producing anything, and then we start seeing them having more severe anemia type problems. So we know it on newborn, but we don't have to intervene until 3 to 6 months. I got a red light that's flashing at me. I guess I'm done. Oh, one more question. I can't hear you. Oh, that's a tough one. Okay, so a 7-year-old who turned out having leukemia but had normal CBCs for months before. Again, that's the problem with it. You've got this insidious type of process. And I've had a couple kids that we followed because of thrombocytopenia. They had slightly low platelet counts, but that was the only thing they had for months, and then everything just fell off the end of the table, and oh, wait a minute, they've got leukemia. So again, it's kind of a clinical mishmash in that you're just going to have to kind of watch them and see where they are, because again, until it turns abnormal, you don't have anything. Thank you very much. I appreciate your attention and coming in this afternoon.